Hi, welcome to Management of Gastrointestinal Tubes and Ostomy Skills Lab. I wanted to give you a narrated PowerPoint online to help you as you study. As you can see, we're going to be covering Chapter 45 and Chapter 48, and there are some excellent resources within these chapters. So if you're not someone who typically reads the book, you may want to read the book for this purpose. So, what are GI tubes and why do we use GI tubes? As you know, if you remember back to anatomy and physiology, the gastrointestinal tract is one big tube. Therefore, if we need to solve problems within the GI tract, we can insert various types of tubes to help that out. What might we want to do? We might want to decompress the stomach. We might want to lavage the stomach, and lavage is a fancy word for flushing out or irrigating. We might use the tube to diagnose GI disorders. We can insert a tube, draw back some aspirate, send the aspirate to the lab, and find out exactly what's going on in the stomach or other part of the body. Typically, what you're going to be doing as a student, though, is using the GI tube, either a Levine tube, a nasogastro tube, or a gastrostomy tube to administer medications and feedings. And we're going to get into a little more depth about that. For certain disease states, you may also use a tube to treat an obstruction. And sometimes they actually use tube to compress a bleeding site. So there's many reasons why we might want to use it, and believe it or not, nurses are primarily responsible for most GI tubes. Nurses put in most of the GI tubes. There are a few we do not, but once they're in, it's our job to maintain them, to manage them, and to troubleshoot them, and most importantly, to assess the patient frequently to make sure that they're not having complications. So what types of tubes are we talking about? Nasogastric tubes are just that. They're put in through the nose into the stomach. If we use the mouth, it's called an orogastric tube. And they're short tubes inserted through the nose or mouth into the stomach and secured in place with tape. So they're indicated mainly for short-term nutrition, or they can be indicated for short-term suction, which would be removal of stomach contents via suction. Nutrition comes in many types. Typically, it's either a bolus, and I'm going to get into more depth about that, or a continuous feeding. So there's two main types of tubes for this purposes. A Levine tube is a basic 1-lumen tube that can be used either for feeding or for suction. A Salem tube, however, is strictly used for suction. It should not be used for feeding unless you really have no other choice. It's designed for post-op patients, for pre-op patients who need to have their stomach decompressed. And in class, I'm going to show you how these exactly work. Here's pictures of each one. As you can see, the Salem is very different. It's a double lumen tube. It's a little fancier. The Levine tube is a straight single lumen tube. These come in sizes, and typically the size that we use for most patients is going to be between a 14 and an 18. So when you have a Levine tube or a nasogastric tube of any type to suction, it's typically ordered as low intermittent or low continuous. And low intermittent suction is usually LIS, the abbreviation you're going to see. The patient is going to be NPO. Think about it. If someone's stomach needs to be decompressed and we have them to suction, why would we want to put more fluid into their stomach? So a patient is NPO if they have their nasogastric tube into suction unless we have a specific order to give fluids. You also need a specific order to give ice chips. Ice chips are not routinely ordered unless there is a reason for it. And the tube should not be clamped for crush medications unless you have a specific order to do that. The tube, I'm going to get into this more in class. I'm going to show you how we insert the tube, but it's very important that you measure the tube and use the specific guidelines of every agency that you work at. Now, on your videos, there is a nasogastric tube insertion on the Taylor DVDs. I want you to look at that, and also in class, we're going to be reviewing that, and I'm going to show you on the mannequin how we actually insert a tube. And I have a great video from England, which I think is even a better video from the Taylor DVD that I'm going to show you because it's very realistic how the patient reacts. Now we're getting into the crux, the really serious part of nursing. How do we check the placement of this tube? This has been debated since I was a nursing student, and now research has demonstrated that the best way to check for placement is to do an initial x-ray. This is usually a portable x-ray done at the bedside, or you may send the patient down to x-ray depending upon your agency protocol, but typically it's a portable chest x-ray. And the tubes are radiopaque, which means that they're visible on the x-ray, and it's going to show us very clearly if it's in the stomach. Think about why this is so important. If this tube was inadvertently placed in the lung, we would kill our patient. We would drown the patient with the fluid. The other way to check is to do a pH of the aspirate. We all know from chemistry that pH paper can be used to test how alkaline or acidic something is. We know our stomach is acidic, so therefore if we do a pH of the aspirate, it should be less than 4. That's a pretty good indication that the tube is in the right place. Another way to check is by auscultation, and I'm going to demonstrate this in class. It's still used at many agencies, however, it's not the most effective. We also need to check for residual if the patient's getting continuous or intermittent feedings. And by that we mean how much is left in the stomach before we give them more. And typically if they're on a continuous feeding and we check the residual and we get 100 mils per hour, we get 100 mils, we don't want to give the feeding. We want to hold it for a while. And we're going to explain that more when you see it in class. We do everything in nursing based upon evidence-based practice. So, as I said, the best way to check for of a placement of an NG tube is by x-ray visualization. This doesn't mean that we do it every time we come in the morning. It's the initial x-ray. If the tube is in good position, then we look at how far the tube is out. We want to make sure we maintain it taped at that position. And if we ever have any reason to doubt that it's been moved or that the patient may have coughed, then we get a repeat x-ray. We're not going to use it until we're absolutely sure it's in the right spot. Again, pH testing of aspirate is very easy to do. However, what we're learning over time is that sometimes continuous feedings change the pH. They alter the pH of the stomach contents, so therefore it may not be reliable. And certain medications, antacids, are going to raise the pH. So again, we may not get a reliable indication that it's in the stomach. Often we will do a visual assessment of the aspirate. We pull back the contents from the tube and say, okay, it's yellowish green, it must be in the stomach. However, if someone has a respiratory infection, they also might have yellowish green secretions, so that's not 100% sure either. We also want to look at how much of the tube is left out, which is one way to know. However, it doesn't let us know if the tube is coiled in the back of the throat. And then again, the auscultation of an air bubble is not real effective, and in class I'm going to show you a picture of why that's so. We also have other types of tube which are very narrow, and these cannot be inserted by a nurse unless they're specially trained. These are nasoduodenal or nasal jejunal tubes. Typically these are called Bolus feeding tubes, so those are not inserted by nurses. But the one that you're going to see often is a gastrostomy tube. Years ago it required surgical placement. Now these are inserted percutaneously in an endoscopy suite. And I know some of you last semester when you went to the OR, you had the opportunity to see these tubes being inserted. It's a tube inserted directly into the stomach, and it's used for long-term feeding. So you may say to me, why, Mrs. Siegel, why does somebody have to have a tube put in? Why can't we send them home with the nasogastric tube from the hospital? Nasogastric tubes from the hospital are not, they're taped in place. And what's the biggest risk factor? Aspiration. So therefore, we don't want to send somebody home with a high risk for aspiration. And this is indicated for long-term. So before we do anything for a patient, before we put the tube in, before we maintain the tube, we always want to be doing patient teaching. We always want to be explaining to patients what we're doing. Sometimes this is not possible if somebody comes in that's a trauma patient. They may be a little bit out of it. They may be semi-conscious, and we need to put a tube in, so we can't do teaching. But for the most part, if the patient's cooperative and understands why the tube is being put in, it's much easier to do if you prepared them and you did some teaching. So we want to do some patient teaching. We want to explain to them why it's being used. We want to do the tube insertion based upon the policies and procedures of the institution that we're working at, and based upon evidence-based practice. We want to confirm placement by an x-ray. We want to secure the tube. Typically tape is fine, but there's also securement devices that many places use. And then we want to do monitoring of the patient at least every 4 hours, if not more often. You want to be checking the placement of the tube based upon agency policy. We want to be assessing the patient's oral status. We want to make sure that they're hydrated. We want to be looking at their nares to make sure that there's no breakdown. And we want to maintain tube function. If the tube is put in there for suction, is it indeed suctioning? Is it working appropriately? If we're using the tube for feeding, are we irrigating it? Are we putting the appropriate feeding in? Are we monitoring the patient appropriately? We want to give frequent oral and nasal care, and we want to monitor, prevent, and manage any complications. Now, nurses put these tubes in, so nurses will be removing these tubes as well. And as students, you can be putting these tubes in and you will be removing them. So what's the purpose and advantages of enteral feeding? Remember, in class, you talked about parenteral nutrition, TPN, PPN. That's parenteral nutrition via a vein. Enteral means food via the GI tract, liquid feedings, tube feedings via the GI tract. And in nursing and in nutrition, we always want to use the GI tract because it's designed for feeding and nutrition. So therefore, the saying, it's very old saying, but it's very true saying, if the gut works, use it. So if someone's GI tract is working appropriately, but they can't eat for some reason, we want to use that GI tract when we can to feed them. It's very safe and cost effective. And the reason for this is it preserves GI integrity. If you don't eat for days, your villi and the different areas of your GI tract start to become shriveled. They decrease in size. You don't get the absorptive capacity. So therefore, we want to maintain its function because we know we need our GI tract to absorb nutrients for the rest of the body. So we want to preserve the normal sequence of intestinal and hepatic function. We want to maintain fat metabolism and lipoprotein synthesis. And we want to maintain normal insulin and glucagon ratios. So our GI tract is very important. And we know that we don't want to be malnourished when we're in a critical situation, we're in a hospital situation. So the best way to feed us is via enteral feedings if we can't eat orally. There's two main types of feeding, and in class we're going to demonstrate these, but a bolus feeding is typically how we eat. Although it seems like for some people you may say to yourself, I've been eating all day. We really don't eat all day. So a bolus resembles a normal feeding pattern. Every 4 hours, every 6 hours, patients get a prescribed amount of liquid feeding. And you always have to assess for placement and residual before you give your feeding. A continuous feeding, however, is small amounts delivered over 24 hours via an infusion pump. It's only over the past 10-15 years that we've been using feeding pumps. Typically, we used to just run them like an IV drip, and then we had many problems where it would speed up. So now they are also given via a pump. And there's certain protocols every institution has. The entire feeding apparatus needs to be changed every 24 hours, and we have to maintain the head of the bed at 30 degrees. And another important thing is that we have to give the patient enough free water. I have often seen patients come into the emergency room dehydrated who have gastrointestinal tubes, who have a gastrostomy tube for feeding, and yet they're dehydrated. And I wonder, how did that happen? If they have a feeding tube, how are they getting dehydrated? And it happens because people forget to give them enough water. And typically we're drinking water throughout the day. We're getting water in various sources throughout the day. And if patients are only relying on their feeding and not getting water, they may become dehydrated. So it's very important to give free water based upon physician's order. So this is typically what a bolus feeding would look like. The formula comes in cans, bottles, all different ways. You're going to be giving a prescribed amount. We want to make sure it goes into the stomach. We're going to keep the head of the bed up to prevent aspiration. And we're going to keep the head of the bed up for at least an hour after the feeding. If somebody's at home and they may want to decide to lay down, you want to make sure they keep the head of the bed up. Medications via your nasogastric tube will be much clearer when I show you in class, and you're going to be doing this on the unit, and you're going to be doing it with your faculty member. You're never going to be giving medications via a nasogastric tube or a gastrostomy tube independently while you're in nursing school. Remember, the same rules apply that for any medication. We're always verifying the order, we're always identifying our patient, we're always making sure that we're not crushing meds that shouldn't be crushed, and we're giving meds appropriately via a tube. Whenever we crush meds and give them via a tube, there's a risk that we lose some medications. Whenever we crush meds, we're never getting the full dose. We want to be as careful as possible. We also want to give enough fluid with each medication to make sure that it gets absorbed properly. So there's certain protocols, and every agency will have different protocols as far as how much you give. Often we have to give 10, 15, 20 meds at a patient at one time. It's not optimum. The goal would be to give them at different times, but sometimes that's not possible. So you want to make sure that you're always flushing so the tube doesn't get obstructed. The nursing process, there's so many different diagnoses for patients who have tubes, depending upon the reason why they have tubes. And we're going to be talking about this in greater depth in class.